So we want to thank everybody for joining us and welcome you to today's presentation of the Family Medicine Grand Rounds for May 19th. Your event code listed here is 139047 for those interested in CME credit. The instructions are there on how to access that, but if you need additional help or information, please feel free to contact the CME office, or you can also shoot me an email. Again, my name is Nicole Rubio. Also, if you are registering, please make sure that you do so before midnight tonight in order to receive your credit. Next slide. So we want to thank everybody again for attending, and as you are joining us, please make sure that your microphone is muted as we begin. Also, if you can remain attentive and engaged in the session, we will take questions during the presentation. If you want to put those in the chat box, I will give those to Dr. Johnson-Esparza. And also, towards the end of the session, I will be putting in the evaluation link so that we can provide feedback to her. So next slide.
Sorry, my computer keeps acting up.
No problem. So this is the South Texas Regional Family Medicine Grand Rounds, and we are partnered with the South Central Area AHEC. And you can see our mission statement there. Next slide. For those who need their CME transcript, you can visit our CME website. The office's website is listed there. And if you are needing help with accessing that website, again, you can call them or free feel to email or give me a call as well. Also, AAFP credit is available. This presentation is for 1 credit. And if you have questions or would like to claim credit, please contact the AAFP. Today's presenter is Dr. Johnson-Esparza. She has no relevant financial interest with commercial interest to disclose. And so she is going to be discussing with us today behavioral health consultation in the inpatient setting. She is one of our assistant professor clinical here with UT Health in the Department of Family and Community Medicine. And I will let Dr. Johnson-Esparza get started.
Thank you. And actually, my title should say in the inpatient medical setting, seeing how there are also other kinds of inpatient settings. This is not inpatient psychiatry, it's inpatient medical. So I'm sorry for not having included that in the title. So we can go ahead and get started. I'm hoping that by the end of this presentation, I will have met 3 objectives. So I hope by the end of the presentation, you will each be able to identify common behavioral health concerns in the inpatient medical setting, list elements of effective consultation liaison, CL from now on, services in the inpatient medical setting. Sorry for that typo as well. And finally, describe how integration of behavioral health consultation into the inpatient medical setting contributes to positively impacting the Quadruple Aim. So now we can go ahead and get to the meat of this. Give me a sec, my computer's acting up a bit. All right, so whenever we talk about the inpatient medical setting, I think it's important that we first talk about the complexity that we find in the inpatient medical setting. And there are multiple factors that contribute to this level of complexity. We have risk factors that are associated with hospital admission and readmission, including psychiatric morbidity. We know that individuals with psychiatric morbidity are at increased risk of chronic medical illness, for instance, cardiovascular disease, diabetes, stroke, among others. And probably not surprisingly to many of you, individuals with comorbid psychiatric conditions do tend to have a more severe presentation of their medical illness, which of course contributes to the risk of admission, the risk of readmission. We know that psychiatric morbidity can make it a lot more challenging for individuals to effectively manage their chronic conditions. So psychiatric morbidity is one of those big ones there as well. Health behaviors are also other factors to consider when we're thinking about the complexity in the inpatient medical setting. And when we talk about health factors, it includes an array of different behaviors, including poor dietary practices, lack of physical activity, Health behaviors do account for about half of all deaths in the US. They do account for a large portion of hospital admissions and readmissions as well. There's an increased number of poor health behaviors let me back up. An increased number of poor health behaviors has been associated with increased risk of hospital admission. There was recently a review of an administrative database with data from 100 academic medical centers, such as ours. And what they found is that among patients that were frequently admitted to these academic medical health centers, they were more likely to have multiple complex chronic conditions, along with behavioral comorbidities that impacted their health behaviors. This often leads to acute episodes requiring hospitalization. This study actually also found that among those with frequent hospital admissions, there was a greater likelihood of multiple comorbidities as compared to those with fewer admissions. I think the value that they offered was like 7 comorbidities to like 2 comorbidities, which is a very stark difference. And of course, these things do impact our adherence to treatment. So it's not a stretch to imagine how psychiatric morbidity, how certain health behaviors can impact patients' ability to, or individuals' ability to adhere to treatment recommendations. Comorbidity of psychiatric and medical conditions is another thing that we often see in the inpatient medical setting. More than a third of medical and surgical patients have psychiatric comorbidity. We know that up to half have a mental health concern that could benefit from some kind of intervention. So maybe not a full-blown diagnosis, but some kind of concern that we could possibly intervene on. This is associated with longer stay in the hospital. It's associated with higher costs. And despite this higher prevalence, despite these costs associated with length of stay due to psychiatric and medical comorbidities, we actually failed to meet the behavioral needs of the majority of these patients. And of course, failure to address these needs will impact or contribute to this risk of readmission. A study in the early 2000s found that less than 5% of admissions received a mental health consult. And as you can look at the stat right here, approximately 35% have a psychiatric comorbidity, but only 5% perhaps are actually receiving some kind of consult to address these issues. And when they do receive these consults, we know that it's often late in the hospitalization to the point that there's already been some level of decompensation perhaps. So just kind of making it a little bit harder to climb out of that. And I think we'd be remiss if we ignore the fact that we ignore the role of social determinants of health in these health behaviors and how these may continue to play out during the hospitalization and following discharge. When we don't have safe housing or transportation or a safe neighborhood where we can safely go out and engage in those 30 minutes of daily activity that our doctors are asking us to, when we live in areas where we have very limited access to nutritious foods, it becomes challenging to also adhere to those dietary practices that they're asking us to stick to, right? And not just that, but when you live in an environment that is inundated with all sorts of pollutants, it also makes it a little bit harder for you to effectively manage your asthma or other breathing conditions. So there are multiple social determinants of health that do impact these the complexity of the patients in the inpatient medical setting as well. Not to mention language and literacy, including health literacy, when we expect patients to read those pill bottles effectively, but perhaps either don't have literacy, or if they do have literacy, perhaps it's not adequate health literacy. And then finally, stress associated with hospitalization. Anybody who's been in the hospital for whatever reason can probably attest to the fact that being in the hospital can be a potentially stressful situation. There's stress related to isolation, and I would say especially during this pandemic, that has probably been one of the bigger issues for many people. The loss of personal autonomy, disrupted sleep, pain, nutrition issues, anxiety related to procedures, limited mobility, worrying about what this hospitalization is going to cost me when I get discharged. All these are factors that make the hospitalization quite a bit stressful. There was a study in 2019 that demonstrated that among patients who reported high trauma during their hospitalization, the risk of readmission within the 30 days following their discharge was higher as compared to those who did not report the same level of trauma. And just to give you an idea of what trauma meant in this study, trauma was just I shouldn't say just, but trauma was a disturbance in multiple domains that they identified. They identified 4 domains, which were sleep, mobility, nutrition, and mood. And high trauma was regarded as 3 disturbances in these 4 domains. So just that can actually have that high of an impact that we might see a readmission within 30 days. So I hope that this highlights the fact that there's a need for behavior interventions in the inpatient medical setting. And if I didn't highlight that last point just now, then I think that's a shame on me. The other thing I want to mention before we move on is that the cost of readmission is high. Hospital readmissions cost Medicare $26 billion annually. And furthermore, I would add that these comorbidities are also associated with a reduced quality of life. And now if we have a reduced quality of life, how does that impact our psychiatric morbidity? How does that impact our health behaviors? And now we're just kind of stuck in this cycle. So definitely a need for behavioral health interventions in the inpatient medical setting. So what do we do when this happens? Well, there are consultation liaison services. This is where we can start talking about these services. And again, CL from now on. Let's break down what consultation liaison means. It's 2 words, obviously. Consultation really refers to the direct patient care, the intervention, assessment. Liaison refers to recommendations and education provided to the consulting provider or the team. And CL Psychiatry has been perhaps one of the busiest CL services across inpatient medical settings. It is an accredited subspecialty of psychiatry. It includes all diagnostic, therapeutic, teaching, and research activities of psychiatrists in non-psychiatric parts of a general hospital. It is sometimes used interchangeably with psychosomatic medicine, but it's not quite the same thing. CO is really the clinical arm, while psychosomatic medicine is more interested in non-clinical issues focused on ideas related to the interplay of biology and psychosocial factors. So a clear distinction there, but if you do hear psychosomatic medicine, perhaps it might be referring to CO psychiatry. CO psychiatry is available around the clock. They're focused on the management of consultations and psychiatric issues that come up in the inpatient medical setting. There are consultations, evaluations for psychotropic medication management. They deal with patient behavior management. For instance, do we need restraints? Do we need to assign a one-to-one? Do we need to make any kind of medication changes for this? Or we have a patient who has an active psychosis. We need to manage this more effectively. Enter CO psychiatry. These are emergency management services, but they do have little follow-up or the use of psychological interventions. So this is where we come in, enter psychology. I should have mentioned at the beginning, I apologize for not doing this, but I'm a licensed clinical psychologist, which is why we'll focus on this part a little bit more. But before we can go on, let's just talk a little bit about, or let's just go over, stroll down memory lane of the world of psychology and just provide a brief history of psychology in medical settings. For that, I think it's also important to talk about the history of psychiatry in inpatient medical settings. It all started early 20th century. There was this growing concern about physical disorders, the psychological origins, and treatment of these disorders. It was largely dominated by psychiatrists who were concerned with diagnosing, and treating disease believed to be the result of psychological conflict. It was very psychodynamic in approach. In the 1930s, an individual by the name of Billings went ahead and established the first CO psychiatry service at a hospital in Colorado, and actually began conducting studies exploring the costs and benefits of psychiatric services. In the 1950s, we see that CO psychiatry grows in popularity and services start to sprout up across the country in many hospitals. At the same time, there was a movement to reintegrate psychologists into the fields of medicine and mental health. folks were more interested in bringing psychologists back into medical departments. And it says reintegrate because following World War II, psychologists were sought after because of many soldiers that were coming back with what we now refer to as PTSD. And so psychologists were widely utilized for the care of these individuals. And so in the 50s, they started getting reintegrated. And then it was in 1976 when a paper was published on the role of psychology in the delivery of healthcare services. This was in the American Psychologist. And the author discussed psychology as both a health science and a health science profession. Also discussed the importance of training psychologists to be able to deliver these healthcare services. Right before that, in the 60s, there had been several developments that also contributed to this growing interest in integrating psychology into the world of medicine. And that was one, the awareness that there was a decline in infectious diseases that was also accompanied by increases in diseases that stem from individual behaviors and lifestyle. For instance, there's an increase in heart disease and cancer. The second thing was that there was an increase in cost related to procedures, medications, the use of technology. This, of course, led to more financial resources being used up. And finally, there was also a growing appreciation of the interplay between biology and psychology. There was the stress and disease became areas of interest during this time as well. For instance, the idea of fight or flight was something that was gaining popularity in that time. So all this just kind of started setting some of the pieces. And then in 1977, we have Engel, who publishes The Need for a New Medical Model, a Challenge for Biomedicine. This was the leading paper in the Journal of Science at that time. And it was really, he was proposing this idea of the biopsychosocial model, which we all know at this point, which has kind of guided our practices. Finally, in 1979, and this I think is the first mention of psychologists in the world of psychiatry, these two authors discussed the need for training psychologists to provide services within psychiatry. And since then, there were organizations that were more dedicated to the advancement of health psychology and behavioral medicine. So these organizations began to form. We started seeing journals dedicated to the field of behavioral medicine, of health psychology. And now we're at the point where there are services that are specific to, or that are comprised largely of psychologists as well. So psychology in the inpatient medical setting, there are multiple models that we can follow when it comes to integrating a psychologist into this setting. One is that the psychologist can be a member of the CO psychiatry service. This is a multidisciplinary team approach that CO psychiatry might take. We can also have a CO psychology service that is exclusively run by psychologists. It's independent of CO psychiatry. And the goal is really to meet the patient needs that are not met by CO psychiatry. Interventions are brief, they're focused. In other words, we're not conducting therapy in the inpatient medical setting when you're, at least in this model anyway. We do know that the majority of CO services are run by psychiatry, though. There is a minority that includes psychologists as part of their service, and very few services are run exclusively by psychologists. There was a review that looked at this, and they looked at several studies that were published from like 1975 to 2001, and they found that psychologists were part of a multidisciplinary CO psychiatry 32% of the time, or sorry, in 32% of the studies, they were part of a multidisciplinary team. When it comes to pediatric CO psychiatry services, though, there tends to be more of a psychology presence there. I think what they found in this study was that 60% of services included a psychologist. Something different about peds CO psychiatry, I think, that just makes it a little more multidisciplinary. The majority of the services, like I mentioned, were run by psychiatrists, and I think that was like 80% of those studies. And only 4% of those studies were run exclusively by a psychologist. In 11% of those studies, so not too many, there were both CO psychiatry and CO psychologist services. And that study is not a very recent study, but I think it's the most recent study I was able to find that kind of looked at what this breakdown looked like. So I think it's clear that when it comes to CL services, it is largely dominated by psychiatry, but there's a definite need for psychological services to be integrated. When it comes to setting up a CL psychology services, it's important that we identify the scope and that we delineate what the roles are, especially if there's already a CL psychiatry service. And in the QI project that I'll talk about later, this is exactly one thing we had to figure out. What's the role of CL psychiatry? What's the role of CL psychology? And how do we work together so that we are not doing the same thing, so that we are respecting each service's areas of expertise. There are unique contributions of psychologists that I think are worth noting. One, psychologists receive specialized training in understanding the role of biopsychosocial factors in disease. So the factors that contribute to the etiology, the maintenance, the exacerbation, the progression of disease. This is an area where we have specialized training. Also assessment and interpretation of validated measures. So depending on the service, that might not be as important of a role as it might in other services. And finally, the application of evidence-based brief interventions. And I'm just listing a few of these evidence-based interventions that have received quite a bit of support in addressing not only mental health conditions, but medical conditions as well. That are typically used in outpatient settings. And although all of these interventions have not been studied thoroughly in an inpatient medical setting, the evidence that surrounds their effectiveness in the outpatient setting is one that I think supports their use in the inpatient medical setting. I would say that CBT is probably the one that has been most widely studied in the inpatient medical setting. So just a few interventions that we can utilize. And I would also add relaxation-based interventions in there as well. And so you can see how this is an area where psychologists might really be able to provide a unique service that might not otherwise be provided by a CL psychiatry service that does not have a psychologist, obviously. Here are some of the most common referral reasons when requesting a consult from CL psychiatry or CL psychology. Diagnostic clarification, adjustment to illness, depression, and procedural anxiety, pain, risk assessment when we need to assess whether there's any kind of suicide risk, substance use is a common one, unexplained medical symptoms, is patient adhering to treatment, can we address any of the family dynamics that might impact the patient's progression of illness or contribute to healthier practices, cognitive impairment, and of course, end-of-life issues. And just looking at these referral reasons, you might see that there are some areas where perhaps one service might be more, I don't want to say qualified, but might have a greater specialty to address some of these referral reasons. For instance, if we're going to talk to somebody about adjustment to illness, perhaps you'd be seeking the support from CL psychology or a psychologist versus CL psychiatry, who might not be able to have the time, the breadth to really address adjustment to illness. And that's where psychologists might also come in. I wanted to bring this up. This is actually from a PEDS CL psychologist service from a CL psychologist text. And I apologize that I didn't include the citation there, but it's in the references. I think it's Cogran or something like that. But they identify the 7 C's of consultation, or some focus areas of CL psychology, and this includes crisis, so the rapid assessment in the midst of acute health-related stressors. This is an area where psychologists play a big role. Coping, adjustment to illness, coping with hospitalization and psychiatric morbidity. Compliance being the other thing. Can we identify what are the barriers to compliance to treatment or treatment adherence? How do we work toward removing some of these barriers? How do we facilitate communication between patient, family, providers, which can be an area that gets broken down very easily and can impact a patient's progression in the hospital. Collaboration, working with teams to build the cohesion between the team, quality improvement projects, investigating the role of behavioral health integration, changing systems, again, continuing to conduct research or advocacy of behavioral health integration within the medical setting, and championing, whether it's for the patient or for the behavioral health service, improvement of availability and access to these resources for our patients. And this is just another area of focus that psychologists can also take in the CL setting that I thought was worth mentioning. Okay, I just want to be mindful of time here. Okay, we've all heard of the Quadruple Aim, I think, and I'll remind you that the Quadruple Aim consists of better outcomes, improved patient experience, decreased cost, and improved provider experience. And so I want to talk about, how CL psychiatry / psychology services can adequately meet aspects of the Quadruple Aim. So let's talk a little bit first about patient outcomes. We have seen there's quite a bit of research looking at outcomes, and there is a decrease. Some of the studies that I will talk about are cited here, but there have been studies that show that there's a decrease in physical complaints, negative mood associated with medically unexplained symptoms. There are improvements in pain, for instance, both chronic and acute pain. And acute pain is one that is actually quite common in the inpatient medical setting, and oftentimes the go-to treatment for something like acute pain might be opioid medication. Sometimes that can pose its risks. Sometimes it might not be indicated for whatever reason. So here, this highlights the need for alternative approaches to the management of acute pain. For instance, behavioral approaches. There's one study that's cited on this slide where the treatment team assessed pain ratings prior to and after an intervention, a behavior intervention, specifically mindfulness. The comparison group, so the intervention group received a mindfulness intervention. The comparison group received psychoeducation, the gate control model of pain. And just to give you a brief overview, the gate control model of pain just focuses on the psychological factors that impact our experience of pain. And it's a way to help people kind of understand how these work. Interestingly enough, both groups actually experienced a drop in pain rating, though it was greater in the intervention group. Stress ratings were only improved for the intervention group, not for the psychoeducation group. But I think the fact that both groups experienced improvement in pain rating suggests that even psychoeducation alone can be effective in helping patients experience some level of reduction in acute pain experience in the inpatient medical setting. And what's more, both of these interventions only took 10 minutes. And in those 10 minutes, these providers were able to see that there was a drop in the experience of acute pain. We also know that from research, psychological interventions or behavioral interventions are associated with decreases in stress, in depression, and anxiety. And these studies that I'm talking about are not these are not medication studies, obviously. These are all going to be behavioral interventions we're talking about here. There was a study that looked at the effects of CL psychiatry on depression and anxiety. They found that the integration of these services into the general medical setting resulted in improvements in depression and anxiety. What was interesting about this study, though, was that they found that although these effects were small, they were similar to those of studies that only used antidepressants. So these behavior interventions that were used in this study were just as effective as the antidepressants that patients were receiving. And then one that actually didn't make it here onto this slide, but I think is worth talking about is a study that looked at myocardial infarction. And patients who were in the hospital for MI received psychoeducation. They talked about cognitions around MI and how their thoughts might be related to behaviors. The psychologists worked with them to develop action plans on how to go about returning to work. They worked on goal setting for behavioral change, discharge planning, and how to address potential barriers. The patients who received this intervention from the psychologists were able to return to work more quickly and were more likely to return to work full-time than those who did not receive the intervention. They also had a better understanding of their illness. They also made fewer calls to their providers the 30 days following, I believe it was 30 days following their discharge. So clearly, even with MI, the CBT approach was effective in improving patient outcomes and getting them to improve their quality of life, their level of functioning. When it comes to experience, though, to patient experience, this is an area that's lacking a little bit. It does require further study. There's not too much out there looking at patient experience. I can only imagine that it's a little bit challenging to gather this level of data while a patient is hospitalized, and probably also post-discharge. And just from our QI project alone, I can appreciate the difficulty with getting patients to fill out a survey on how satisfied they were with the service when maybe they're on contact precautions or when they are under the influence of the medication or just currently sedated because of the medication that they're on. So it can be a little bit dicey at times. So definitely more studies needed in this area, but there have been some studies that have shown that there's a level of satisfaction following brief intervention. One that I cite here was in the study looking at patients who received an intervention for self-harm after a suicide attempt, but were hospitalized in the general medical setting. There was a higher level of satisfaction following the brief intervention. And in that last bullet, the brief psychosocial intervention associated with improved satisfaction, there's an asterisk there because that's actually a pretty interesting study. The brief psychosocial intervention in this study was actually not delivered by psychologists. It was delivered by physicians. And it was a brief psychosocial intervention designed to reduce distress and strengthen physician-patient relationship, which we know is associated with better patient outcomes. But the reason why I wanted to include this study on this slide is because the individuals who can help train clinicians or physicians to provide this brief psychosocial intervention are the psychologists in the team as well. This is one of those liaison roles that psychologists can play in the service, providing or equipping the treatment team with the tools to be able to provide appropriate care to patients, to improve communication skills. And we saw in this study that this psychosocial intervention was associated with just that improved satisfaction. And actually what they found in this study was that it wasn't the fact that the physician maybe spent more time with the patient. It wasn't that maybe the patient had a better understanding of their health condition, but rather they attributed this improved satisfaction to the patient feeling like their relationship with the physician was better. So that's just a really neat study because it shows the role of a psychologist or the indirect role of a psychologist in patient satisfaction. Okay, so now let's shift to the other side of this pizza-like circle and focus on improved provider experience and lower costs. When we talk about this, though, I want to talk about a newer model of CO psychiatry called proactive CO psychiatry. Proactive CO psychiatry is more of a population-based approach to the management of behavioral health concerns in the inpatient medical setting. So rather than being reactive, so in other words, waiting for that consult to come on, in proactive CO services, the team will actually seek to identify those who could benefit from an assessment, from a possible intervention. The CO team participates in the interdisciplinary rounds with the goal of identifying these patients. Proactive CO services not only result in what we have seen from the data is that proactive CO services have resulted in an increased sense of physical safety among providers. They've also been associated with a reduction in burnout and a reduction in emotional exhaustion. They have also been associated with teams feeling like they have better confidence, better support, like they have better communication skills. And so all this is from this more proactive approach to addressing to trying to meet the needs of the patient population. And recall from earlier in the presentation that only 5% or that mental health consults are made in only 5% of admissions, at least according to that one study I cited. So this is really a way of trying to hit more people. We also know, and again, it'll be proactive CO services that I talk about again when it comes to costs, because we also know that these are associated with a reduction in length of stay. And as you can imagine, costs, because if you're staying and spending less time in the hospital, that also means the costs are going to be lower. The reason why is that this allows for an intervention prior to the psychological decompensation of a patient. It allows for an intervention earlier on in the treatment process. And so I think that's one thing that's been really important about these proactive services. I would add that not only is it crucial to intervene early when there are psychiatric concerns, but when there's a need to explore and or plan behavioral modifications as well. The literature does suggest that one factor that contributes to readmissions is not having a good sense of what needs to take place following discharge. So planning for discharge early on, helping patients identify potential barriers, helping patients identify facilitators and try to set up their support systems can be conducive to a better experience post-discharge. Okay. And one more thing, actually, reduction in readmission. Proactive CO services have been associated with a decrease in readmission. There was one study that showed, pretty recent study that showed that there was like a 10% decrease in readmission following CO psychiatry, proactive CO services. Related to the length of stay, I think it's important to note that the length of stay is reduced, particularly when services are provided early on in the care of the patient. And regarding that last point of efficient use of resources, when proactive CL teams conduct or sit in interdisciplinary rounds with the treatment teams, there is this discussion that can be had about the multiple needs that a patient might have. Perhaps the CL team does not need to actually go see the patient. Perhaps they simply need to convey some information to the treatment team so that the treatment team can then go about the care of the patient more effectively, or perhaps it's just requires a simple visit or perhaps a full visit. So when we're able to sit around sit around or participate in rounds, there is this opportunity to identify what's going to be the most efficient use of those resources. Okay, so now this is the part that I'm actually a little bit more excited about, simply because this refers to the QI project that I've been alluding to, or sorry, now we get to the QI project I've been alluding to. The behavioral health integration in inpatient medical setting, a quality improvement project. And just to give you a little bit of background, I want to tell you a little bit about our family medicine hospital service. It provides acute care at University Hospital for patients receiving primary care at Robert B. Greene Family Health Center. I should mention that the hospital service also provides care to patients that are under the care of other family medicine providers across the primary care clinics in town. The patient population, for those of you who are not familiar with the area, the patient population served by the Family Health Center is one that is it's quite medically complex. It has multiple morbidities, including diabetes, CKD, hypertension, psychiatric disorders, sometimes all of the above. And many of them are also experiencing multiple psychosocial factors that are associated with poor health outcomes, whether it's poverty or unemployment, disability, food insecurity, housing instability, and the list goes on. And we talked a little bit about those social determinants of health and how those impact a patient's ability to adhere to treatment and take care of or effectively manage their chronic condition. So this is the patient population we serve in the family medicine hospital service. But also to give you a little bit more background of how we even came to be, I think it's worth mentioning that at the Family Health Center, we provide primary care behavioral health services, PCBH. And PCBH is a team-based primary care approach to managing behavioral health and biopsychosocially influenced health conditions. This model integrates a behavioral health consultant or BHC into the primary care team. And the BHC functions as a generalist who knows a little bit about a lot and is able to assist with the management, not just of mental health concerns, but of other health conditions as well. And so it seems like this model, seeing this model in action really perked the interest of leadership, and they realized that this would be an approach that would also benefit the inpatient medical service as well. But it was not until my colleague, Dr. Gibson Lopez, and I came on board that we were finally able to provide this level of service to our patients in the inpatient medical setting. University Hospital does have a CL psychiatry service. And at one point, a few years ago, they did have a psychologist as part of their team who provided services to the entire hospital 1 day a week. So there's clearly been a need for addressing or for meeting the needs of our patient population. Currently, the CL psychiatry service does not have a psychologist. So in order to meet some of this need, like I mentioned, my colleague, Dr. Gibson Lopez, and I have been providing services to our inpatient medical setting service once a week, and we actually rotate every other week so that there's someone consistently on Wednesdays. I should say that the need is still really great, and just today I was just getting slammed with a lot of requests for patients to be seen. So it's wonderful to be able to provide this service here. The goals of integrating our service into the inpatient medical setting are threefold. One was to improve the patient outcomes and quality of patient care during hospitalization through direct patient care. So this is that consultation piece. This is us going in and providing services to our patients. The second is to promote continuity of care beyond the primary care setting. And when we're working with patients from the Family Health Center here, we're lucky that we get to follow up with them when they go back to the clinic for their discharge follow-up. So that's been the nice level of continuity of care we've been able to offer our patients. And finally, to provide education to family medicine residents on contextual assessment, diagnosis, treatment of patients' behavioral health needs. That's that liaison piece that we talked about earlier. Okay, and typically when we focus on direct patient care, we identify the patients that could benefit from a behavioral health intervention during our table rounds. So we'll actually sit with the residents and the attending and discuss patients during table rounds, identifying who are the ones who might benefit from a visit, asking, have we considered this? Perhaps we could try this one thing, and just going about our day that way. The visits that we offer are brief, they're focused interventions, they're typically 20 to 30 minutes. Caveat there, 20 to 30 minutes, but in the hospital setting, sometimes there are multiple interruptions with nurses having to come in for meds and other teams coming in. So we shoot for 20 to 30. Sometimes it's more like 40 when there are multiple teams coming in to try to also meet the needs of the patient. I've gone ahead and added the common referral reasons to this slide again, but I'll give you an idea of what are the ones that we often get called up for, or like the most common for our service. And that's adjustment to illness, depression, anxiety, panic, pain, substance use, treatment adherence, and coping and skills training. These have been among the most common reasons that we get called up. I feel like adjustment to illness is probably one that we consistently get referred on a weekly basis. And resident education is another one of our services. We provide curbside consults during table rounds or as residents are going in and out. We also have the opportunity to sometimes provide some feedback following observation. So if we happen to do a visit with a resident or join a resident on a visit, following that visit, we're able to provide some feedback to the resident on something we might have noticed, or a different way of approaching an issue with a patient. And that's another neat activity that we get to do with residents. We also provide a didactic education. It's a brief 10-minute education. It's not the longest, but in the inpatient medical setting, sometimes 10 minutes has to carry, like we have to squeeze a nice chunk of information in those 10 minutes. And the BH faculty deliver this didactic education during table rounds on multiple topics, including the topics that I have listed here. Behavior change, patient contextual factors, mental health in the inpatient medical setting, communication, resident wellness. Just last week, we talked a little bit about stress management, relaxation skills, not only for the residents, but also as skills that they might be able to implement with their patients. And our quality improvement project, really the goal of this QI project is to assess patient and resident satisfaction with the integration of behavioral health services in the family medicine hospital service. Patients and residents have completed satisfaction surveys since October 2020. Residents, this is a patient satisfaction survey. It's a little bit out of order, but patients complete an 11-item survey following their behavioral health visit when possible. When there are contact precautions or other issues, sometimes we're not able to get that survey out, but even still, we've been able to get a good chunk of these surveys. Residents fill out a resident satisfaction survey, a 7-item survey at the completion of their 4-week rotation. And I want to thank our residents for filling these out. I do bug them a lot for these. And so I'm going to show you a little bit of data. I'm only going to show you descriptives. We haven't really conducted any statistical analyses around this, but I want to let you know that our scores are generally high. And this is a Likert from the scoring. Let me go back to the scoring. We're looking at a Likert scale from 1 through 7, where 1 is strongly disagree and 7 is strongly agree. And for the most part, we see that patients are quite satisfied with the service. The lowest scores that you see here are for my visit was too short, my visit was too long. We actually do want that score to be a little bit on the lower end because we want that visit to be just right for them. It is it's a fast-paced setting. We can't really spend the traditional 50 minutes or 60 minutes with a patient, seeing how big of a need there is. Okay, so for the most part, we see that there is a high level of satisfaction for the visits for patients. And when we look at, let's look at some of the statements patients have made, some of the qualitative info we've gathered from patients. Patients have actually been quite appreciative of the services. And sometimes what they say doesn't make it onto the survey, but there has been quite a bit of appreciation. Someone, for instance, said, it's something I needed, but I would never have requested this on my own, perhaps because it's not a service that often gets offered out to patients. There was one patient who said that being a patient multiple times, I'm used to getting my vitals checked. It's comforting that my mental health is considered more vital. And I thought that was a very, telling quote from a patient. And not just that, but like I mentioned earlier, we get to follow up with patients at the Family Health Center following their discharge and get to continue working with them at times. As far as resident satisfaction goes, we also see that the ratings are pretty positive for the most part. There aren't any ratings that are below 6. For the most part, residents have expressed a certain level of satisfaction with the service. And residents have also, for the most part, I think residents have actually been asking for more days in IPS, which has not been possible, but they've requested 2 separate days of the week for us to come in. That would be beneficial. So that patients who don't have a prolonged stay can benefit from services. Some noting that patients appreciate the time that the BHC dedicates. I like this last one. I think it's been helpful to know that we've got BHC to help us communicate and understand some of our more difficult patients or patients that have anxieties, feelings of depression, etc. while in the hospital. It gives us another layer of understanding of them, and have that available, and having that available has been incredible. So what I really like about this is that point of it gives us another layer of understanding, because one of the things we also want to be able to do is to make sure that residents feel comfortable working with these patients as well, that they feel like they're equipped with some skills that can also help them effectively manage behavioral health issues that come up. These, like I mentioned, residents are busy managing labs, orders, consults. They don't have the time to really sit down with patients. but BHC is able to help out with that. And again, hoping that the service could be expanded a little bit more. And so with that, I want to just come back to the summary. I think I'm doing good on time. So 3 points I hope are the takeaways. Patient complexity due to physical and behavioral health concerns is prevalent in the inpatient medical setting. CO services can effectively address behavioral health concerns in the inpatient medical setting. And finally, the integration of behavioral health services in inpatient medical settings positively contributes to the clinical outcomes, patient experience, costs, and provider experience. So the quadruple aim. And now, if you have any questions or comments, I'm happy to answer these.
Oh, I do have a comment, and that would just be both in the outpatient and the inpatient setting. I think we've got a really progressive model that we have to integrate behavioral health services into primary care. I think we're ahead of the curve. I think that is the way things are going to continue. And so when you, for the residents, when they go out into practice, keep that in mind and look for other ways in different settings that you can incorporate these services for our patients. We're trying to demonstrate the benefit of that, and I think we've had some success with that here. When we were strolling down memory lane, I put in the date. I think we started the integration of behavioral health in the FHC in about 2015. And so that should have been on, that could have been on the list. And then the other thing is, when did we start the integration on IPS? 2019?
No, it was, wait, was it 2019? Oh man, I think it was 2019. I think I said 2020.
It was 2020. It was the height of COVID.
Okay, sorry. COVID just has me really like, I'm not sure when we started. I don't even know how long I've been here.
It was the beginning of this academic year in July, last July.
All right, so
that's right.
There's a couple of markers for your slide when you're given a similar version of this 10 years from now.
I will. Good note. Thank you.
Thank you, Dr. Johnson-Esparza, for an excellent presentation. You show us the reflections from the patients and from the residents, but what are the reflections from the BHC's perspective of having been in the inpatient service?
Thank you for that question, Dr. Hyan. I think it's an important one. It's difficult work. I can definitely appreciate how challenging it is working in the inpatient setting. At the same time, I think it's also very gratifying. Oftentimes we're working with patients in the outpatient setting and we don't really have an understanding of what they've been going through while they've been hospitalized. We don't have an appreciation for how stressful that experience has been for them. That experience alone has been stressful for them. I think just yesterday, Dr. Hen, we had a case with a patient who had a really stressful experience. And I think being in this inpatient medical setting, we're able to appreciate that. And I think that can also inform how we work with our patients in the outpatient setting. So I think it's been gratifying, challenging, yes, but work that you love should be challenging, I think.
Thank you, I agree.
I was noticing the happy birthday banner behind you. So if it's your birthday, happy birthday. If it is somebody else's birthday greeting, then happy birthday to them.
It's not. I'm borrowing somebody's office, but thank you. I'll take the birthday wishes.
Happy birthday to Dr. Davidson. It is his birthday today.
Happy birthday.
Any other questions or comments? I did put the evaluation link in there. If we can have as many people as possible help us please to fill out that evaluation so we can give some feedback. But otherwise, I want to thank everybody for joining us today, and thank you, Dr. Johnson-Esparza, for a wonderful talk.
Thank you, everybody. I appreciate the attention.